بسم الله الرحمن الرحيم. اليوم الثاني من مؤتمر الجمعية الروماتيزم الأردنية بالتعاون مع جمعية أطباء الروماتيزم الفلسطينية مع الجمعية أو اللي هو المشرق العربي. أيضا بنرحب بكم جميعا، بالإخوان من فلسطين، من سوريا، من لبنان، وإخواننا من العراق اللي ما يقدروا يكونوا معنا اليوم. صحيح، فأهلا وسهلا بكم. بنبدأ اليوم our first speaker اللي هي دكتور سيما أبو السعود. She is a consultant pediatric rheumatologist. She is assistant professor of pediatrics, faculty of medicine جامعة القدس ومستشفى المقاصد بالقدس فلسطين. Dr. Sima, she is going to talk about mass danger, timely recognition and management of macrophage activation syndrome. بنرحب بالدكتورة سيما وأهلا وسهلا بك. تفضلي.
Good morning everyone. Thank you for the introduction. I'd like first to take this chance to thank the scientific committee, as this marks the first time that we have dedicated pediatric rheumatology sessions in our Levant summit, and this highlights the recognition of the urgent and special needs of our young patients. Today, I'm talking about a masked danger, timely recognition of macrophage activation syndrome. I hope I'll be able to give you some tools to help you unmask it in time. So the objectives of my talk are to recognize the early warning and clinical signs of macrophage activation syndrome before it's too late. To navigate the current diagnostic guidelines to guide a timely diagnosis, and to initiate a rapid treatment plan, including key biologic therapies to improve patient outcomes. So I'll start my talk with this case presentation that we often see in real time, not only in pediatrics, but for our adult colleagues. You might encounter such patients, whether you are adult rheumatologist or internist. So it's for a 5-year-old male who was previously doing well with unremarkable past medical history. Our patient was doing well till a week prior to starting having fever spikes, chills, and sweating. He additionally had arthralgia, myalgia, and decreased oral intake. So initially he was thought to have a flu illness. So unfortunately, he persisted to have fevers. He presented for the first time at an outpatient clinic at day 7 of fever. So given the prolonged or persistent fever, CBC was done, and it showed a white blood count of 13.9 with neutrophil predominance, hemoglobin 11.5, normal platelets, high CRP of 54, and mildly to moderately elevated liver enzymes with normal urine analysis. So again, he was thought to have probably influenza, and he was managed with oral antibiotics, assuming he had throat infection, and he was given ibuprofen for the joint pain. So it was day 14, and still our patient is having fevers. So this time the decision was made to admit him to hospital. He had fatigue, migratory small and large joint pain, and he started developing a pruritic rash over his arms and legs with the ongoing fevers. So this time the hemoglobin was lower. We have thrombocytopenia. The inflammatory markers are rising, and the ESR was high, and the liver enzymes were more elevated, as well as the creatinine. On exam, he had the diffuse rash, no arthritis, tip of the spleen was palpable, no hepatosplenomegaly or lymphadenopathy. So what do you think is the most likely diagnosis? Is it infection, malignancy, SLE, systemic onset GIA, or another inflammatory condition? So the differential diagnosis at this stage is broad. It could be any infection, it could be malignancy, it could be an autoimmune disease, it could be systemic vasculitis, mainly Kawasaki disease with this prolonged fever, or it could be other diseases, sarcoidosis, maybe reactive arthritis or HLH MAS. Additional investigations done to our patient showed a normal chest X-ray. This time the abdominal ultrasound showed mild hepatosplenomegaly. The echo showed small pericardial effusion, no coronary involvement. ANA and rheumatoid factor were negative. So cultures were taken, including blood and urine, and the patient was started on IV antibiotics with a persistent fever, escalation of antibiotics. And then, assuming this could be atypical Kawasaki disease, he was given IVIG. The fever still persisted, and here is the evolution of his labs. The hemoglobin was decreasing, the white count as well, the platelets. The CRP was more rising, and it was until day 17 that a ferritin was done. During that time, arrangements were done to do a bone marrow aspirating biopsy for our patient to rule out a malignancy, and then he was started on IV methylprednisolone, but not knowing what the diagnosis was. So later on, this patient started having confusion, hypotension, a rash on the body with active joints, and he was admitted to ICU and then transferred to tertiary hospital. Unfortunately, at the time he arrived to a tertiary hospital, he was intubated, he had pulmonary hemorrhage, he had multi-organ failure with coagulopathy, liver failure, and renal failure. And he was really in a very critical situation. So other blood work that was done, the double-stranded DNA, the ANA profile, the ANCA were all negative, complements were normal. Extended infectious workup was negative, including brucella, which is common in our area, COVID as well. So after exclusion or other diagnosis, the patient was given the diagnosis of systemic GIA complicated by macrophage activation syndrome. So what is MAS? MAS is an acute, overwhelming inflammation that is caused by a cytokine storm. It's a life-threatening complication of various rheumatic diseases with a mortality that can reach to 30%. And it bears close resemblance to HLH. So what happens, like trying to simplify what happens in MAS, so there might be some genetic predisposition in some patients together with an inflammatory, hyperinflammatory status background, given maybe the underlying rheumatic disease of our patients. And if there were triggers which could be infection or sometimes could be the activity of the rheumatic disease itself, this will initiate the cytokine storm. There will be increased activation of T cells, which will lead to release of interferon gamma, and this will lead to activation of macrophages and their expansion, and the ongoing cycle will go on with this cytokine storm. So you will sometimes hear, is it HLH, is it MAS? So to classify HLH, we have the primary or the genetic HLH, in which some genetic mutations are identified. And these patients usually present very early on, sometimes shortly after birth. And it could be the secondary, acquired, or reactive HLH, in which in rheumatology we like to label it MAS, macrophage activation syndrome. It is mostly secondary to autoimmune and autoinflammatory conditions, mainly systemic GIA, adult onset Still's disease, adult and pediatric SLE, and Kawasaki disease. Secondary HLH could also be secondary to infections, malignancy, or other causes. What about the clinical manifestations? Patients can have an acute, severe, dramatic presentation with unremitting fever. They could have organ evidence of hepatosplenomegaly, lymphadenopathy. They could have mental status changes, bruising, bleeding, and sometimes, if not detected early, they can proceed to have multi-organ failure, coma, seizures, encephalopathy, hemodynamic instability, myocardial inflammation, pulmonary hemorrhage, renal, liver failure, and coagulopathy. So when these dots are interconnected, these are the mass alarming bells that we should pay attention to. And what about the evolution of the lab features? We know in any inflammatory state, we are expecting thrombocytosis, leukocytosis, very high inflammatory markers, high ferritin. However, what's special in MAS that as the course evolved, these patients start to have pancytopenia. The ESR will be strangely low in a hyperinflammatory status, and this will be due secondary to hypofibrinogenemia. And why these patients have hypofibrinogenemia? Due to the liver involvement and consumption. So we should pay attention to the trends. Now we talked about the activation of these T cells and the macrophages, and here are a number of important or emerging biomarkers that are expected to be high in MAS: the soluble interleukin-2 receptor alpha and the CD163. These are shedded from the surface of the T cells and macrophages respectively, and can sometimes help us to detect MAS early on. So CD163 also has a role in the hyperferritinemia, as it will bind the ferritin haptoglobin complex, and this will initiate the pathway that will lead to hyperferritinemia. Also, there is a pivotal role for interferon gamma, and sometimes the measurement of the interferon gamma chemokine-induced CKCL9 might be a more reliable marker. So we know that hemophagocytosis is virtually diagnostic of MAS. However, it is not specific or sensitive. Sometimes it's only seen in 30 to 60% of the cases. This could be related to the time of it could be related to the timing of the procedure, or sometimes early in the course, so we might not see hemophagocytosis. But not having hemophagocytosis in the bone marrow doesn't know that the diagnosis is excluded. Now, coming to the guidelines for the HLH, we know the diagnostic guidelines for HLH. It is made if we have a familial or genetic diagnosis, or a diagnostic criteria in which 5 of 8 are fulfilled. So going back to our patient, he had fever, he had splenomegaly. However, the criteria wasn't met early on in the disease course, but later as the disease evolved, the patient developed cytopenias, hypertriglyceridemia, hypofibrinogenemia, and hyperferritinemia. So this is to tell you we should not rely on guidelines. We shouldn't say our patient have 5 of 8, okay, it's on, or 2 out of 8, so this is not MAS, because at the time this criteria is fulfilled, it might be too late, and we might be losing our patient. So we would like to detect our patients early on before the full-blown picture of MAS is achieved, because as I said, at this stage, the mortality is very high and we might lose our patient. So this is the classification criteria for MAS in systemic GIA. It's for the criteria says that in a febrile patient with known or suspected systemic GIA, we can classify the patient as having MAS if the patient has a ferritin of more than 684 and at least 2 of the following 4 lab abnormalities: platelets below or equal to 181, AST above 48, triglycerides above 156, and a fibrinogen of 360 or below. So again, this is only for systemic GIA. So our patient again fulfilled this criteria. However, there is no good diagnostic criteria for MAS. Why is that? Because the manifestations of MAS, of systemic GIA, SLE, and some of our rheumatic diseases, they overlap. So in systemic GIA, we have high fever, lymphadenopathy, hepatosplenomegaly, and hyperferritinemia, natural killer cell dysfunction. The disease could be triggered by infection, introduction of certain medications. SLE, again, they have high fevers, they have lymphadenopathy, hepatosplenomegaly, hepatitis, and cytopenia, in addition to the CNS dysfunction and bleeding tendency. So back to our patient. The patient received 2 doses of IVIG, methylprednisolone, IV pulses for 5 days. Luckily, we were able to provide him with anakinra, and initially he received a high dose of anakinra, initially 3 times a day, 5 milligram per kg per day. We were planning to add cyclosporin as well, but he had severe hypertension. And fortunately, the patient responded well to the treatment, and he was discharged home in a very good condition. I saw him last week. He's on anakinra and 10 milligrams of prednisone, and we are weaning the dose. So regarding the treatment of MAS, I look to it as a pyramid. So first, in the base, we should stabilize our patient, provide ICU support. We should treat any triggers, treat the underlying disease. We should, of course, suppress early on the disease with high doses of corticosteroids, which are often given as IV pulse methylprednisolone. Sometimes we can give IVIG as an adjunct, or if you want to do bone marrow till doing it. But of course, this depends on the situation and clinical status of the patient. Corticosteroids and IVIG might not be the clue in some cases. They might have ongoing manifestations, so if you might need to use targeted therapy, interleukin-1 blockers like anakinra, cyclosporin A, and if these patients did not respond, we will go to rescue therapies. Etoposide sometimes, which is used in the HLH protocols, is used. Imapalumab, which is an interferon gamma inhibitor approved in 2018, and the management of primary HLH is a promising treatment. Talks about JAK inhibitors. Ruxolitinib is also a possible a treatment in the future. So my take-home messages for you is that MAS is a potentially fatal complication that may occur at the presentation of the disease during the disease course. It requires timely diagnosis and management. Don't wait for a full criteria. Sometimes it is difficult to discriminate from active disease. We should always watch the trends, and ferritin is our best friend. Finally, early expert consultation is crucial. We should hit hard and hit early. In this MAS danger, it is time to unmask it. Behind every unexplained fever or lab spike, MAS could be hiding. Early recognition saves lives. Don't let it stay masked. Thank you very much.
شكرا دكتورة سيما for sticking to time.